Hello everyone, I am Dr. Sapkal here. The title for discussion today is HIV infection in pregnancy or mother to parent child transmission. Estimated HIV infection in India is and the population living with HIV is approximately 12.1 million. Among them, 39% are women, 7% are children below 15 years, and national adult HIV population is 0.27%. Transmission of HIV infection is maximum 90% with transfusion of blood and blood products. Contamination, occupational hazards, transsexual transmission is approximately 0.1 to 1%. Minimum transmission is there with the drug abuse, that is 0.05 to 1%. Regional prevalence is also described in the form of high prevalent region, moderate prevalent region, and less prevalent region. High prevalent region means STD prevalence is more than 5% and antenatal cases with HIV positive serology are more than 1%. Least prevalent means both STD and ANC are less. In between is the moderate prevalent region where STD are more than 5%. However, antenatal population with HIV positive serology is less than 1%. WHO has given certain direct diagnostic criteria for clinical aid. There should be at least two major criteria and one minor sign to confirm that the lady has got AIDS. Minor criteria are prolonged fever and chronic diarrhea both for more than 1 month and weight loss more than 10%. These three criteria are included in minor signs. Major signs are cough, pruritus dermatitis, herpes zoster, herpes simplex infection, generalized lymphadenopathy, and oropharyngeal candidiasis. These six criteria are included under the major signs. And there are two indicators of AIDS, Kaposis sarcoma and cryptococcal meningitis. If these two conditions are there, they are the indicators of AIDS. As such, when the patient gets HIV infection in pregnancy, there is no further progress of this disease with pregnancy and there is no associated increased maternal morbidity or mortality due to HIV infection. As such, clinically, HIV infection manifests with and progresses in 4 stages. 4 to 6 weeks is a period of incubation and it is a period of seroconversion also. Initially, the lady develops asymptomatic disease within a few weeks with adequate CD4 count approximately 350 to 500. If CD4 percentage is less than 14, then there is risk of thrush, hepatitis A, hepatitis B, influenza, and pneumococcus infection. Mild disease develops within few years and subsequently the CD4 count reduces to less than 250 and with advanced AIDS, CD4 count is always less than 200 with other opportunistic infections like PCP or pneumocystis, carni pneumonia, toxoplasma infection, Mycobacterium avium and cytomegalovirus infection are also seen along with the advanced conditions of AIDS disease. Whenever the lady gets HIV-2 infection, the progress of this disease to AIDS is very slow and there is less transmission to the child with pregnancy. The treatment of this is same like 2 NRTIs plus LPV is included and neonate receives AZT in place of nevirapine. If lady has got both HIV 1 and 2 infection, then previous same regime as for HIV-1 is continued, like TDA plus 3TC plus EFE. If the patient has got HIV infection and hepatitis B also, in these cases, nevirapine is avoided and protease inhibitors are also avoided because these drugs are associated with hepatotoxicity. Mother to child transmission of infection in pregnancy, or the determining factors for vertical transmission, mm, the risk is 20 to 45%. In pregnancy, at term, there is 20% risk of transmission. The risk is more if high HIV RNA viral load, low CD4 count, presence of P24 core antigen. Primary infection during pregnancy also is a risk factor for mm, child transmission. Then associated genital tract infections in pregnancy, drug abuse, unprotected sex with multiple sexual partners, or whenever invasive procedures like amniocentesis are conducted in pregnancy, these patients they are at risk of developing mm, vertical transmission to the fetus. In intrapartum conditions, there is 30% risk. The risk is more with vaginal delivery, instrumental delivery, prolonged labor, and use of episiotomy in second stage of labor. After delivery, the risk is 40%, and just before delivery, the risk is 50%. After delivery, if neonatal endotracheal suctioning is done or breastfeeding is given, or whenever the baby is low birth weight baby or premature baby, then the risk is 40% with delivery. 50% is the risk before delivery. Whenever there is a premature rupture of membranes, duration more than 4 hours, repeated PV examination, fetus scalp blood sampling, and chorioamniotis is associated with pregnancy. In these cases, the risk is highest, 50%. Perinatal transmission can be divided to mother to child transmission, 20 to 40% in pregnancy. The transmission can occur in labor or delivery also, and with breastfeeding. So 40% is the risk with the breastfeeding for perinatal transmission. There are 4 goals of PTCT program. Primary prevention of HIV infection in all women. The second goal is prevent unwanted pregnancy and referral. That's why their referral should be done for family planning center if patient develops HIV. If HIV positive woman is pregnant, then she should be referred to ART centers to prevent MTCT along with treatment of HIV, ART treatment. Subsequently, after childbirth and during pregnancy, the treatment and care and adequate support should be given, and ART should be continued for the newborn up to 6 weeks. Aim of this MTPCT program is to detect HIV positive pregnant women and link these women to the healthcare center. This is the main aim. With that, the perinatal transmission will reduce. The significance of this need of preconceptional treatment in the female is very, very important, should always be explained to the woman, and she must receive ART in the form of 3 drugs, that is TDF, 3TC plus AFE. With this ART treatment, there is maximal suppression of maternal viral load before she conceives. And the second criteria is patient should be referred to the family planning centers to motivate her for contraception to prevent the unwanted pregnancies. Prenatal HIV screening. ACOG 2008 recommends routine HIV testing for all antenatal mothers. The approach of this screening should be right for refusal or opt out approach. In high prevalent area like HIV prevalence with 1 in 1000 population, repeat screening for HIV is required in the third trimester. Screening tests used are ELISA test, it is very sensitive, rapid test and dot plot test. Pre-test counseling is done about the effect of this HIV infection on the fetus, risk of mother to child transmission of infection, and practice of safe sex. If patient reports in emergency with labor pains and if the HIV testing is not done prior in pregnancy, then rapid HIV test is done in the labor and positive rapid test should next be confirmed by Western blot or IFA. If that positive rapid test is then patient should be subjected for ART before delivery. Post-test counseling is very important. If the test is negative in a pregnant patient, then explain her about the window period, which is approximately of 3 months, and she needs to get her serum tested. Repeat after 3 months. If HIV test is positive, then report is disclosed one-to-one basis with most confidentiality. Advice about the immunization, partner testing is also given simultaneously. Then discuss about she has to avoid the smoking or use of tobacco, avoid use of alcohol, drug abuse, and she has to practice the safe sex. Appropriate contraception should be advocated to her to avoid unwanted pregnancy and its importance should be discussed with her. Informed choice about the MTP in case she is pregnant or continuation of pregnancy must be discussed on the first visit itself. Routine antenatal care is carried out at least there should be 4 visits throughout the pregnancy. 2 doses of tetanus as usual are given, first on booking visit and next before expected date of delivery. Iron tablet, folic acid supplementation and screening for IUGR is very important in pregnancy. Aim of MTCT program is to reduce the vertical transmission. WHO advocates lifelong ART for pregnant women and breastfeeding women as ART reduces MTCT of HIV to less than 5%. Attention to the choice of breastfeeding or top feeding should be given. If non-breastfeeding woman with HIV infection is there, the risk of newborn transmission is 20% and breastfeeding woman with HIV infection risk to newborn is 40%. Hence, practice of ART, use of ART in pregnancy, mode of delivery should be LSCS and avoid breastfeeding will reduce the HIV transmission risk to 2%. If the HIV test is positive in pregnancy, counseling of the patient is done about the perinatal transmission. Referral for ART centers for ART treatment, and if the lady has got acute primary HIV infection, then simultaneously identify P24 core antigen or viral RNA load. The test of partner is also advocated. Contact the tracings also. If HIV screening not done prior to the patient and she reports in the labor room with the labor pains, then rapid HIV test is done to detect the antibody. If the test is positive, it is confirmed by Western blot or IFA test. Immunization advice should be given for all HIV positive pregnant women. If prophylactic vaccination is not provided in pre-conception period, then hepatitis A, B, influenza and pneumococcus prophylaxis is given in pregnancy. Post-exposure prophylaxis is required if patient gets in contact with hepatitis A, B or varicella zoster exposure is there. So this prophylaxis is given in the form of immunoglobulins, which are given through IV route. Vaccination for measles is contraindicated in pregnancy, in all pregnancies, of course, in HIV cases also. Examinations and investigations are subsequently done, and their referral for ART center is very important, where WHO cleaning staging is done. In each trimester visit, CD4 count and percentage of CD4 and plasma HIV RNA PCR should be done. Complete blood count, KFT, LFT, and look for hepatosplenomegaly. Screen for hepatitis B as other STI or STDs like HSV, syphilis, chlamydia, gonorrhea infections. If bacterial vaginosis and candidiasis is seen, treat them promptly. Trimethoprim sulfamethoxazole or cotrimazole double strength tablet, 1 tablet per day is required. If the patient gets pneumocystitis kernel infection with CD4 count low as less than 250 cells. If the CD4 count is less than 100, then she is at risk of getting toxoplasma, anti-toxoplasma, IgG positive, IgG titer will be positive in these cases. There, cotrimazole prophylaxis is important. Then Mycobacterium avium intracellular complex. In these cases, prophylaxis is given for these infections. The goal of ART is to reduce prenatal transmission by reducing the viral load with the ART treatment. Pre and post exposure ART prophylaxis is also important for infant also. What are the principles of ART? Highly active antiretroviral therapy must be started, and combination of 3 drugs is always ensured. Monotherapy is contraindicated in HIV positive women. 98% of HIV mothers with ART treatment give birth to HIV negative children, and they do not transmit HIV infection through breastfeeding. What is this? What is the classification of these antiretroviral drugs? There are nucleotide reverse transcriptase inhibitors, non-nucleotide reverse transcriptase inhibitors, and protease inhibitors. The rest are entry inhibitors, receptors, CCR5 receptor inhibitors, and integrase inhibitors. Among them, among nucleotide RTS, tenofovir or TDF 300 mg per day is used, and lamivudine means 3TC 300 mg per day is used. Along with that, third drug is non-nucleotide reverse transcriptase inhibitors. In these cases, efavirenz is the drug. The dose is 600 mg per day. So these 3 drugs, TDF, 3TC plus EFV, is used as a first line of drug. If the patient develops toxicity or cannot tolerate this regime, then zidovudine is added in place of TDF. Or protease inhibitors can be added, that is lopinavir 50 mg BD. This is the choice for HIV-2 infections. Recommended first line TDF plus 3TC plus EFV 300 plus 600. If intolerance, then we have discussed zidovudine should be added. What is the purpose of this ART? It suppresses the viral load to its maximum. Should be the purpose or aim. Prophylaxis for opportunistic infection, clotrimazole plus folic acid should be given. If previous ART exposure, then 1 tablet of TDA plus 3TC plus LPV is added, leponavir and ritonavir, 50 mg, 2 tablets BD. If previous ART exposure is there. Universal precautions, they are observed when we are dealing with the HIV positive mothers in the labor room or the ward. All patients as such should be considered. All patients' body fluids should be treated as infectious since it is not known who is infected. Use of adequate clothing, mask, gloves, apron, eye cover, using of devices with safety measures should be practiced. Then hand washing, proper hand washing and aseptic precautions are of extreme importance. Use of barriers to prevent blood and blood fluid contact. Avoid spillage of body fluids and disinfection is practiced with use of ethanol 70% or formalin 3 to 4% or sodium hypochlorite 1 gram per liter or glutaraldehyde 2% for 30 minutes. The other disinfectant is chloramine 20 gram per liter. Sterilization may be practiced with use of autoclave or boiling for 30 minutes. Safe collection and transport of blood and organs. Safe disposal of sharps and blood contaminated materials. Staff protection and immunization is of extreme importance. Promote hepatitis B vaccination in the medical staff. Prevent percutaneous injuries by eliminating unnecessary use of needles and safe work practice for handling these sharp objects must be learned. Management of patient in labor, universal precautions we have discussed should be observed. Adequate nutrition should be given in labor. Partogram management is done for early diagnosis of prolonged labor and to augment the labor also. Avoid repeated PV examinations and avoid ARM also. In second stage of labor, avoid instrumental delivery and episiotomy. Third stage, active management is of extreme importance and use of oxytocin after birth. No milking of the cord at birth and cut the cord once pulsations stop. Safe disposal of placenta and the body fluids. In the labor room, whenever the lady reports without screening test for HIV, in these cases, counseling is done and with consent, screen the whole blood finger prick test. If detected HIV positive, start TDA plus 3TC plus EFE. Ensure immediate linkage to ART centers also. Preterm labor, if she has got, then use of steroids, tocolytics, along with ART is practiced. Vaginal delivery is discouraged as such. LSAS is advocated in all patients if viral load is not known or viral load is very high. Exclusive replacement feeding is advocated when AFAS criteria fulfilled, means affordable, feasible, acceptable, sustainable, safe, fulfilled. Mixed feeding causes mucosal abrasions in the intestine and it is not advocated because it will enhance HIV infection. If bottle feed is not feasible, affordable, then only breastfeeding is advocated. Exclusive top feed in infancy is advocated as such. When protecting the baby from HIV infection, what are the different steps? Start ART to the baby at least for 4 to 6 weeks. Cesarean section is done when the patient has got HIV positive is HIV positive and formula feed is advocated for all newborns at birth. PPTCT and NACO guidelines. AZT treatment, nevirapine is given to the newborn 2 mg per kg, single dose within 72 hours after birth is important. If the mother is on ARV, continue the same ARV. Or zidovudine may be added to the neonate. Stop nevirapine at 6 weeks. So maximum 6 weeks is given. It may be extended to 12 weeks. If the mother has not received adequate ART in pregnancy, means she has not received the therapy at least for 24 weeks. Early infant HIV infections diagnosis is done by DNA PCR at 6 weeks, 6 months and 12 months. Immunization of infant as usual is done, and neonatal cotramazole prophylaxis is carried out till 18 months of child. Universal precautions for health personnel should not be forgotten. Contraception advice: HIV positive women can practice OC pills barrier contraception because 80% risk is reduced with the consistent use. Avoid DMPA because it adversely affects the HIV related immune system. Avoid use of IUCD if she is a high risk patient for STD. PAP test should be done prior. Counseling for safe sex single partner relationship is advocated in all. If female not infected, only male partner is infected, then IUI with sperm washing or donor insemination may be carried out. Treatment of genital tract infection is important in all HIV positive cases. Thanks for watching this video.